Hello and welcome to the session, Possible Medical Interventions. Today we will talk about these subjects: routine interventions, labor induction, pharmacological ways to relieve pain, possible interventions to facilitate childbirth. A positive and natural childbirth experience will favor the mother's recovery, the sense of accomplishment, the bonding between the mother and her baby, and the initiation of breastfeeding. Healthy women, when they are well prepared and supported, have what it takes to deliver their baby naturally. However, certain interventions may be necessary to improve the childbirth experience or even to save lives. Regardless of the intervention, your physician or the nurse will support you and explain the situation in order to help you make informed decisions regarding your childbirth. Let's start with the interventions that support routine care during childbirth. The peripheral intravenous device is a medical device that allows the placement of a catheter into a peripheral vein in the form of a thin, flexible tube. It is used to infuse fluids such as a solute or medication in the bloodstream when necessary. Once the catheter is introduced in the vein, the device with the needle is progressively removed while the catheter advances further into the vein. Once the installation is complete, there is no more needles and you can move more freely without any restrictions. The PID will be installed when you are admitted at the hospital, so the medical staff will be able to act quickly if necessary. The solute is used by intravenous infusion to compensate for the important fluid loss, or as a solvent to administer medication. During childbirth, it will be connected to your PID if necessary and used to administer medication in case of epidural anesthesia or a cesarean section, if the mother is dehydrated, in case of postpartum hemorrhage. The role of obstetrical nurses is to support the woman who gives birth and to ensure the well-being of the mother and her baby. In order to check on the baby, they will monitor their heartbeat with an ultrasound device in the same way as during your medical appointments. This method helps the mother stay active throughout labor. In certain situations, they might use a fetal monitor to ensure a continuous fetal monitoring. For example, in case of labor induction or stimulation, epidural anesthesia, concerns for the baby's well-being. Labor induction is practiced with the consent of the pregnant woman for medical reasons. Here are a few examples. A pregnancy that goes beyond 41 weeks. To reduce the risks of uteral placental insufficiency, because beyond 41 weeks and 6 days, the effectiveness of the placenta to provide the baby with the nutrients and oxygen starts to decrease. Pregnancy-induced hypertension. This syndrome appears during pregnancy and is associated with hypertension and proteinuria. It can develop into a renal, liver, cardiopulmonary, neurological, or blood disease. It requires close monitoring during the pregnancy in order to detect the potential evolution of the syndrome. Giving birth is the only treatment. Medication is only used to reduce symptoms. An unstable gestational diabetes requires rigorous, regular monitoring in the GAR clinic. It's the most common cause of macrosomia. When poorly controlled, increases the risk of the fetus to have immature organs. Ruptured membranes. There is no advantage in waiting for labor to start after the rupture. This increases the risks of chorioamnionitis. However, waiting can be discussed with the physician if the mother chooses so. Serious diseases, mother, cancer, psychosis, etc. Baby, important growth retardation, too low amniotic fluid, malformations, intrauterine fetal death, amniotic fluid infection, serious risks of maternal and neonatal sepsis, broad-spectrum antibiotic therapy. In short, labor induction is indicated when the risks associated with the extension of the pregnancy, both for the mother and the fetus, outweigh the risks associated with induction and delivery. If this applies to your pregnancy, take time to discuss the reasons and possible consequences of labor induction and the different options available with your physician. Once the decision is made to induce labor, several factors must be taken into consideration, including the cervical favorability. If the cervix is not favorable, cervical ripening must be considered before inducing labor. Cervical ripening consists in using pharmacological or mechanical methods to soften, efface, and/or dilate the cervix in order to increase the chances of successful vaginal birth. The methods used are stripping. During a vaginal examination, the physician pushes away the membranes from their attachment to the cervix to stimulate the production of hormones, prostaglandins, and help dilate the cervix. Often practiced during the last medical follow-ups because it may induce labor if the woman is at full term and her cervix is already favorable. Foley bulb. Installation of a balloon in the cervix, which is inflated to help dilate the cervix. Show the catheter. Cervidil. Small cotton rectangle inserted into the vagina, soaked in prostaglandins that will be released for 12 to 24 hours. Favors the softening and effacement of the cervix. It can sometimes induce a labor, can be repeated up to 3 times until the cervix is favorable to dilation. When the time has come to induce labor, there are 2 options. Misoprostol. It is a tablet administered orally or intravaginally that causes contractions in order to induce labor and/or favor cervical ripening. Intravenous oxytocin. Hormone that causes contractions administered in a solute or as a continuous infusion. Requires the constant presence of a nurse. Given by intravenous route until the contractions are strong and frequent enough to dilate the cervix. Requires continuous fetal and contraction monitoring, but it can be suspended at intervals of 30 minutes if the infusion is stable and labor is well underway. Stopped after the delivery. In some cases, during active labor, contractions are present but they are not effective for the cervix. In these situations, we want to stimulate labor in order to strengthen contractions. For example, artificial rupture of membranes. To help strengthen or induce labor, the uterus better contracts, which often speeds up labor. This intervention is usually no more painful than cervical examination, and it does not hurt the baby. The physician will use an amniotic membrane perforator or a finger cot. Intravenous oxytocin. Same medication and protocol as labor induction, but adapted to the fact that there are already contractions. When the support received and the non-pharmacological method used are not enough to manage sensations and pain, pharmacological means can be used to help the mother tolerate pain and contractions. Sedative. Fentanyl. Helps relax between contractions in case of difficulties. Similar effect to endorphins, namely a sense of well-being. It can help the woman regain control of her delivery and/or relax her body. Does not anesthetize the pain caused by contractions. Remember that pain plays an important role in the physiological process of childbirth, as it stimulates the secretion of endorphins and sends messages to the brain on the progress of labor. Potential side effects of fentanyl: nausea and vomiting, pruritus, hypoventilation, incomplete pain relief, dizziness, drowsiness, dysphoria, sense of loss of control. It is important to consider the impact on the fetus if you give birth too soon after the injection. The baby could have side effects such as neonatal respiratory depression, effects on behavior such as reduced reactivity and sucking reflex, delayed initiation of breastfeeding and shorter duration of breastfeeding. Therefore, the nursing staff will not administer a sedative at the end of active labor or during the transition phase. It is particularly important to monitor these side effects when a sedative is administered to the mother within 2 hours prior to the birth. Epidural anesthesia helps reduce the intensity of pain during labor and delivery. It is the most efficient method to relieve pain during childbirth. It consists in inserting a flexible tube between 2 vertebrae in the lower back, through which a solution containing a local anesthetic is injected. This solution helps numb the nerves in the belly and upper legs. It is exclusively administered by anesthesiologists. Epidural anesthesia takes effect after 10 to 20 minutes. It is generally administered as a continuous infusion during labor and until delivery. Epidural anesthesia should not be administered too soon to ensure that labor is well underway. On the other hand, if it is administered too late into labor, you may not have time to receive it and be relieved before the pushing stage. Epidural anesthesia should be administered while considering the progress of labor and the woman's medical condition and preferences. For example, it can be administered if the woman is exhausted or suffering, or if labor does not progress. In general, for epidural anesthesia, laying down is recommended, and the rolling technique should be used to maintain a certain degree of mobility. Epidural anesthesia is a generally safe intervention, and its potential side effects are short-term and minor. Here are a few examples. Temporary drop in the mother's blood pressure, nausea, vomiting, itching, difficulty urinating, which may result in the need to empty the bladder through a urinary catheter, dizziness, pain to the needle site in the back, which may last a few days, numb legs and difficulty moving them, shivers. Under epidural anesthesia, it is sometimes difficult to know how to push, which may extend the pushing time. Therefore, the need to use tools such as a vacuum extractor or forceps to help the baby come out is more frequent. After dilation is complete, certain tools or methods may be necessary during the pushing stage in order to help the baby come out. These interventions are always carried out with the mother's consent. The vacuum extractor is placed onto the back of the baby's head to gently guide it while the mother pushes. It could be described as a small flexible bowel related to a suction device by a tube. The main reasons to use the vacuum extractor are prolonged second phase of labor or obstructed labor, where the baby no longer progresses through the mother's pelvis, when the baby's head is not properly positioned, when the baby shows signs of fetal distress, maternal exhaustion. The use of forceps is rarely the first option used by the physician to facilitate birth. However, they can be very useful during a more difficult labor or delivery, or to help prevent cesarean section. Forceps are a claw-like tool used to grab the baby's head to facilitate the delivery. They are made of two branches that are introduced separately and assembled once they are into position. Like the vacuum extractor, forceps are used to guide the baby out of the mother's vaginal tract. However, unlike the vacuum extractor, which uses suction, forceps use traction. They are used by gynecologists for the same reasons as the vacuum extractor. They are used based on the physician's assessment. Local or regional anesthesia is carried out before the intervention in order to relieve the mother. Episiotomy is an incision made in the perineum where the baby is about to come out. It is rarely used because it increases the risks of larger tears. It could be used to accelerate delivery or to allow for the use of forceps or the vacuum extractor. For any questions regarding the content of these prenatal capsules, you can contact your region's perinatality nurse.